Fortunately, we missed it because of the time that I'm being asked to
No, I'm very sorry.
No,
I
that's
wanted
okay,
to go back to my ARC and thank my speakers there. It's in the 2 floors below. I'm so sorry.
No, that's okay. But now we have only 8 minutes, Chitra.
Yeah. I'll try to keep it as brief as possible. Thank you very much, moderators on the dais and my dear audience. I think this is one thing which challenges us. How do you deal with an unhappy premium IOL patient, even though the patient is 6'6"? Now let's now understand we are not a few years before. The present day, unhappy 6'6" patients is actually a very rare problem because there have been some studies which have been going on to analyze, and one particular Concerto study says that 94% of the patient operated in one eye for multifocal wants multifocal in the other eye, and a similar analysis came in Harmony study. And a recent US FDA study also on the recent IOLs, multifocal IOLs, premium IOLs, said that 97% of the patients wanted a multifocal in the other eye, and only 88% wanted a monofocal. Having said that, we cannot overlook the fact that there are a few who are unhappy, and these are the 7 C's which we need to look at, which I would be taking you through as I go on. Let us understand we are not going to get defensive just because we think we did a great surgery. Our duty is to ferret out the problem and find out why should a patient waste his time in our OPD if he were doing well. We also need to separate the problems from that which are likely to resolve with time with neuroadaptation. You need to find out whether it is a kind of a visual disturbance like a glare or a halo which will disappear. Is it a lack of clarity only for near and intermediate but the distance is good? Is it that the vision was pretty good initially and became not too good later on, which could be an early PCO developing or a CME which needs to be looked into? So we need to search everything right from refraction, tear film, all components of the tear film, the IOL centration, the PCO, the macula. Now, if the patient has a refractive error which is small, you could think of doing a PRK or a LASIK. PRK would be fine if the corneal thickness, topography, everything allows. But if the patient is a very unhappy patient and he wants immediate results and is blaming you for the multifocal, and if the refractive components, the cornea is good and all that, you could consider creating a flap and going ahead and doing a LASIK for him. But let's understand, if the patient has a hyperopic residual refractive error, better than doing a corneal-based procedure, it is better to look at doing a piggyback IOL for those kind of an extreme situation, or remotely, you could even do an IOL exchange. Now, IOL exchange is something we should keep for the last, but the video is not running, but not so late that the capsule is fibrous and becomes difficult to remove the lens and leave the haptics in the capsular bag or similar. Piggyback IOL is another option, though a costlier version, but we do have the Indian components of piggyback IOL. Importantly, you need to have a larger optic lens, and there should be a curvature space. There should be the posterior curvature of these piggyback lens is concave, so there is no interlenticular fibrosis, and they have undulating haptics which gets well seated, gives stability. And of course, you need to look at the void, but these are different ways of addressing this extreme problem. Now, if in a toric IOL the patient is unhappy, then you could go on to the Barrett's RX formula or astigmatic fixed formula. But if you go on to the Barrett's RX formula, we will tell you that do you need to do bioptics for this patient? Would rotation suffice for this patient? Or would you need to do IOL exchange? Now, this was a patient, you can see he has a residual refractive error. And if you look carefully, if you can see from there, the spherical equivalent is nearly 0. Now, these are the kind of patients who would benefit by doing a toric IOL rotation, which was what was done for this patient. But then there was a small area of dialysis, and a CTR was also placed, which ensured that the lens was well centered and the rotation was addressed. But if you find that there is a residual error, which the toric IOL rotation alone will not suffice, then it's best to do straight away a laser vision correction than doing two multiple procedures. It is most important in a premium IOL segment to use those optical biometers, look at the raw data, validate your measurements. Is there something which is wrong between the two eyes? Please be involved in the process. And remember, we have to treat even the smallest amount of astigmatism. And if the first eye is not doing too well, even if 6'6", you need to go slow because we need to understand how you treat it. Like this was a particular case where the patient did well, a great surgery, but was not happy with the near vision, although the distance and intermediate were good. So he was an avid reader. So what we did was place a Technis multifocal IOL with a +4 ad in that eye, and he did well. This was another case of a symphony done in one eye. Patient was happy with the distance and intermediate, but had this little unhappiness for near vision. So what we did was, did a micro monovision in the second eye and kept it just a 0.75. If you make too much of a difference between the two eyes, there would be a loss of stereopsis and contrast sensitivity, which you would not do. And this was a case where the patient had one multifocal, Indian multifocal, and somehow was just not happy, had higher order aberrations on the eye trace, and then we did the different lens in the other eye, and that seemed to solve the problem. So there are different ways by which you address this patient. We do have different choices of lenses. You could use a low ad in the primary eye and a high ad in the second eye. You could add a high ad in the second eye if the near vision is not good. You have an EDOF in one eye. You could do micro monovision EDOF in the other eye. You could combine a trifocal IOL in another one eye with an extended range of vision in the other eye. The other areas where we need to be concerned is the cornea and the ocular surface. It is very important to evaluate the dry eye status in every single patient of yours. If it is a pre-existent dry eye, look at what component of dry eye is it. It is evaporative dry eye, something to do with the meibomian gland, something to do with the aqueous deficiency. Look at it, treat it, and then take up the patient for a biometry. Even the biometry will go haywire. But if it is caused by the surgery, rather, this particular study says that many normal-looking patients, there were 60% of them who had a higher tear breakup time was less than 5, they had corneal staining. And if these are not tested, we would have so many more unhappy patients. Cataract surgery itself could cause dry eyes by the corneal nerve dissection, or if you have a prolonged surgical time, or the preservatives in your drops, or there is some kind of a local ocular surface inflammation which has happened because of the cataract surgery, or a meibomian gland dysfunction. Now this particular lady had a great Schirmer's before the surgery, but after surgery she had very severe dry eyes, and after treating her with topical steroid drops and true lubricants and hot warm compresses, she was quite fine. What is most important is that we need to keep the ocular surface stable in one and all of these patients. When it comes to the capsular bag, you think there's a PCO, oh, that's the cause, I would hit the capsule. No, you wait for 3 months, you find out all other causes of visual disturbances, and remember, rarely you might have to do an IOL exchange, so breaking the capsule should not be the first option. It could be even a CME which is sitting there, and we need to treat that eye, rather than going and jumping to solve a PCO which you think is so easily done in your hands. Look at the centration of the IOL, whether the rings are well centered. Rarely if it's a patient operated elsewhere, the haptic was broken, you don't know. Only intraoperatively you even get to know that it was a decentered IOL. But sometimes just a nudge is enough. And nowadays the way the lenses have come have a larger optic zone. So even if the angle alpha is more than 0.5, even up to 0.8, it is forgiving. So these are the greater advantages which have come. Even if the rexis is not well centered, an asymmetric back contracture, that could cause decentration. And again, this was a patient who had a residual refractive error and a decentered IOL, and all that we needed to do was to just realign the toric IOL, place a CTR and get it okay. I'm not going to show you a femtocataract surgery. Definitely, it takes away most of the challenges. We need to look at the various issues which are there over the retina, to look at all of them. So do a pre-op OCT in one and all of your premium IOL patient. Look at the dysphotopsia. It could be a positive dysphotopsia, it could be a negative dysphotopsia, and invariably the modern lenses which have a square edge design, who have a high refractive index, these could be the cause of dysphotopsia. But again, neural adaptation takes care of most of these problems, and IOL exchange should be the last thought in your mind. Again, if it's that temporal shadow which is coming, which is negative dysphotopsia, besides the causes of the IOL design, it's because of the way the light gets refracted from the edge of the lens and the posterior surface of the lens, and you could do a reverse optic capture in an extreme situation or place a piggyback IOL in these eyes. Finally, I would like to say, you need to choose the right kind of patient. You need to spend that extra time for your patient. You should be mentally prepared for an IOL exchange as a last cause. But if you have planned well in advance, you have a range of IOLs. And most importantly, even if the patient has a small residual error, he is happy, but not 6/6. Don't go and touch the patient. Pat him on his back and tell him that he's doing well and both of you are happy. In other words, a conceptualized approach which keeps your mind open to all the possible challenges would definitely pave the right path. Thank you very much.
Thank you so much, Chitra, for the very comprehensive coverage of a fairly elaborate topic. I think you had an overview of the different aspects of a premium intraocular lens implantation. I really feel that this is not confined to some premium surgeons, but each and every one of you is capable of taking it up and enjoying the benefits of it maximally, both to your patient's benefit and your benefit. Thank you so much for joining us for this course. Thank you.